Thank you all for joining us today for our functional weight loss discussion that we have every month. Today, we're going to be talking about creating stability really in this unstable GLP industry. And, it's been a whirlwind. And I'm sure all of you that are out there have experienced variances as it relates to not only weight loss, but the GLP industry. So we're really excited to bring this topic because, we live and breathe this stuff every single day. So for the sake of introduction, for those of you who do not know who I am, my name is Sherry Stoka, and I'm joined here with Erica Gutierrez, and we are registered dietitians and functional nutritionists. We are on a mission, and we are on a mission really to unite dietitians and functional nutritionists to reshape the future of weight management. And that is kind of a loaded statement, but we believe that there really is a lot of work to do. There's a lot of misinformation out there, and we truly are the experts. We believe that we will be the ones who drive profound change in this chronic disease and obesity pandemic. So dietitians are critical players in weight loss, as most people understand. And working in weight management now for probably 15 years now, it really became obvious to us that the approach to weight loss was not what it was kind of what we needed to do to take care of people. And it was, we're trained in school that, it's the calorie counting and the exercise. And if we just create that calorie deficit, things are going to improve. But I think most people understand now that it is much more than just calories and exercise. Weight loss resistance is real and it's multifactorial. And so that's why our approach to weight loss is in a functional manner. And we take many different approaches with our patients, and that's really what our goal is to really teach and collaborate and expand our knowledge in this area. GLPs are the future. And, the majority of people, now 1 out of 6, and that probably has changed even to this day, have been on them or they are currently on them. So they are definitely they're definitely the future, as it relates to weight loss. But, now we're looking at so many other chronic conditions that have potential, to improve because of these new medications. So the reason why we have so much experience in this area is because I started a weight loss business in 2015. So it's called Weight Loss MD. And I am the only medical weight loss clinic owned and founded by a registered dietitian. So as you can imagine, the approach to weight loss is very different than if you were to go to like a medical weight loss that is owned by like a nurse practitioner or a doctor, because they don't have the training that we have as dietitians. And then when you look at the functional part, we're really looking at the full picture. Erica joined Weight Loss MD at the beginning, and we've been working together and really creating different programs to help people lose weight for the last 10 years. And that's what really drove us to really understand what was going on in the body, and how could we address these multiple imbalances that were really holding people back. We consider ourselves experts in weight loss. We consider ourselves experts in the GLP-1 medications. We manage 20 to 30 GLP-1 patients on a daily basis. So we really fully understand. We try to stay updated on all the nuances, the new information that's coming out, that's forever out there in the news and the media. And that's really a big part of our mission as well, is to educate, really educate our colleagues, which is you, because I do think, at the end of the day, dietitians often get a bad rap based on how we do approach weight loss. So we really just want to be that platform to really excel, enhance our skill set, as a profession. So the agenda for today, I'm gonna do a quick overview on the medication mechanism of action, just to get us on a level playing field. We will talk a little bit about the medications and is it the root cause of obesity? Is it not? We'll talk about switching medications, transitioning off the medication, what happens when a patient stops the medication, and again, we'll talk a little bit about the importance of metabolic health, and then we'll end with a discussion. We will also highlight our training course, our GLP training course for dietitians that we have that's coming soon in the next couple weeks. Okay, why and how do these medications work? And this is literally like, 101, because GLPs do many different things. But for weight loss, they do three main things. They improve insulin sensitivity, they reduce hunger by acting on certain receptors in the brain, and they delay gastric emptying. So those three things are really contributing to a patient's ability to lose weight. So really think about those things, because we're going to talk more about, okay, when you think about, weight loss resistance, and you think about the state of health that the majority of people are in, we always like to go to the root, and the root really is, this dysregulation of blood sugars, insulin resistance, and that type of thing. So it is help supporting that, which is, a lot of patients need nowadays. So we have three main medications that are on the market. You have the GLP-1 agonist, which is the Wegovy and Ozempic. So that's semaglutide, which again, I know everybody knows this, but I like to always just provide a summary of where these fall, under specific categories. So the GLP plus the GIP is your tirzepatide. The brand names would be Mounjaro and Zepbound. And then we have the retatrutide, which is the triple agonist, and that effect on the body includes all three of these components. So the GLP-1, the GIP, and the glucagon. So it is an ever-evolving state of companies researching more and more and how they can enhance, these medications and what they do in the body. But this is what is available today. Okay, so we are going to start with a poll. And the poll has popped up. Do you think these medications address the root cause of obesity?
So there's no right answer here yet, I don't feel, but it's interesting to see what people are choosing. So sort of is winning. More people are saying that. There's still a lot that do not know. A little bit yes, a little bit no. So I would say the sort ofs are winning.
Okay. And we are gonna dig into it, because we kind of have our opinion on it, and hopefully by the end, you guys will have a better understanding of what these actually do and how we can, obviously best manage patients. So, all right, let's continue on. So one of the most important things to think about is, okay, these are medications, right? So they're technically peptides. Peptides are strands of amino acids, and they say it all the time, they mimic normal physiology. So that really pushed me to dig deeper into this, because Being the owner of the business, and I kind of say this all the time, but being the owner of the business, I have friends, I have family, I have a lot of people coming to me for help, and I need to make sure that these medications are safe. So being a peptide, I understand peptides. I know they are signaling molecules in the body, but when you look at our native GLP in our body, it is a structure of 30 amino acids. And its half-life is 1 to 2 minutes. So I'll kind of circle back to that, but I want to compare it first to like the semaglutide. So the synthetic form of semaglutide is a 31 amino acid chain. So it's very similar, but they've kind of structured in a different way so that the half-life of the medication was longer. So not only did they add an amino acid, but they also added a fatty acid. And over years and years of obviously, research and trials, they were able to come up with semaglutide that had a half-life of 165 hours. So that's why you're able to take the injection once a week. Earlier in the whole GLP kind of arena, when liraglutide first came out, that came out as a once daily injection. So a lot of patients didn't like that. So there's been so much research done in this area. So now obviously it's a once a week injection. And so I always would ask, I'd ask the question, do synthetic GLPs mimic normal physiology? So just in that statement alone, showing that normal GLP activation happens in 1 to 2 minutes in the body, and then it goes back down to baseline. When you inject that, the activation of the GLP-1 hormones basically stays elevated for 7 days, okay? And then 7 days later, you're taking another one. So you get this elevation of GLP activation and signaling basically at all times. So you ask the question, what are the potential long-term effects of these chronic elevations of GLP-1s? And there's not really a lot of research looking into this. What I will say is that semaglutide has been on the market for over 20 years, and there really isn't any, serious side effects that have been reported. But now, there are so many different iterations of these medications coming to market. So we do have to take a step back and say, okay, we don't have long-term data on this now. We know semaglutide, that is pretty, that's been pretty standard, that it's been around and it's showed its safety profile. But now we have to be more alerted to, potential new medications coming on the market, which there's a lot of them. So the other question is, does the body recognize the injection as a normal process, or is it something foreign to the body? And with semaglutide, there actually is studies showing that the body doesn't know the difference between the GLP structure of the synthetic versus the native GLP. So that's good. So the immune system isn't, attacking or responding to it. But you also have to, again, remember that even though it's recognizing it as normal, it's still performing a different mechanism because it's staying elevated for basically the entire time the patient is on the medication. So hopefully that made sense. And then the other piece is receptor saturation. So the whole point of triggering and activating GLP-1 or GIP is these gut hormones will signal to the receptors all throughout the body. So you've probably heard that there's receptors in your brain, there's receptors in your heart, there's GLP receptors in your kidneys, in your liver. So there's GLP receptors all throughout the body. And that's why, people are getting some of those ancillary benefits. But you have to wonder, is there some sort of saturation that's happening, and is that potentially contributing to this plateau kind of effect that people are experiencing? So we talk a lot about this in our course because there's many different ways to go about handling certain plateaus and things like that. But rather than just assuming that the patient maybe is not following the plan that you have with them, or some other factor, it really could be just that the medication has reached like a threshold and you need to do something different. So why have we lost the ability to activate our GLP-1 receptors? So what is supposed to happen in a normal state is we eat food. We eat real food, so not the standard American diet, but we would eat real fats and real fiber and real proteins, and certain nutrients will activate the GLP-1, the GIP, the gut hormones, and then they do their thing and they signal to all the receptors throughout the body. But that no longer happens anymore because of multiple reasons, and this is a really important thing to understand, because we've gotten to a place in this modern world that our body just isn't even functioning the way that it should because of our state of health. So one of the big reasons is the standard American diet is highly synthetic. So we are not feeding our body, we're not feeding our gut the nutrients and the fiber that it needs. So the standard American diet is causing, leaky gut, a dysbiosis in the gut. And when you have a dysbiosis or leaky gut, now you have inflammation. You have cellular inflammation, or you have gut inflammation, which leads to a reduced enteric neurons that are supposed to play a huge role in the GLP production. And that's, patients are experiencing a reduction there. And then, of course, you have the excess visceral fat, which is contributing to systemic inflammation and shunting the activation and the production of gut hormones as well. So the fact is that, basically we shouldn't be where we are today. We shouldn't, I mean, the majority of people now want to be on these GLPs because of what they're experiencing. They're starving all the time. They have sugar cravings nonstop. They can't stop thinking about food, right? They cannot stop thinking about food. It's like one of the main things that we hear all the time. Just turn off the switch so I can just not think about my next meal. So, and it's sad because if we can just get that body into a healthier state and have some of these things happen naturally, we'd obviously be in a much better place. So metabolic dysfunction is a huge problem. It is estimated that the majority of Americans have some level of metabolic dysfunction. I know that means many different things. But when you think about what these GLP medications do, they improve insulin resistance, right? They have an effect on the pancreas. They're affecting the beta cells to produce more insulin. The majority of people need that. I mean, this is the root of metabolic dysfunction. So then, kind of going back to our question, is it addressing the root? And, hence improve GLP signaling, because if you don't get GLP signaling, you're not getting all of those benefits, as well as like the ancillary benefits that affect like the liver and the heart and the kidneys and things like that. They're shown to improve energy balance, and there are many studies showing that it decreases inflammation in the body. So, we're going to circle back with and hopefully bring this all together, but it's just something to think about, because if we can just get people in a healthier metabolic state, what will that mean for that patient? All right, I'm going to switch gears for a little bit. I have a couple more slides, and then then Erica's going to take over. But In this, what's happening now is a lot of corruption. It's a lot of pharma, compounding pharmacies. There's a lot going on. And so patients are now like, they're getting desperate and they're switching products we're hearing that, oh, they used to be covered and now they can't get it. So when you are working with someone, there's going to be many reasons why you may need to switch to a different medication. So product availability, kind of just what I said, side effects, maybe the medication stopped and they need to try something different, or maybe the cost. And I'm going to go through our basic guidelines of how, guidelines for switching patients to a different medication or a different mechanism. But if you would like, you can refer to this study. If you can see it, you can take a screenshot, and it does provide a more thorough description of kind of switching patients from one medication to another. And it's a really good article if you want to refer to that. But here are the general guidelines. There's really no delays that are necessary. So you don't have to stop someone, you don't have to stop like semaglutide for a month before you go to tirzepatide. You can literally transition as if you were continuing the same medication, but there are nuances to that. You can, if a patient has been on the product for a really long time, and again, depending on why they're choosing to switch the medication, it might be beneficial to kind of take a little break, so you can rest the receptors, kind of get the body to, go back to somewhat of its natural state. We have found that, having patients take breaks it can be really helpful. It is recommended, or I think that's also what they recommend in that study. But what we do as far as the doses is we start 1 or 2 doses below the equivalent dose. So let's say someone is switching from semaglutide to tirzepatide and they were on the max dose of 2.4 milligrams. Well, we'll look at the equivalent dose of tirzepatide and then we'll go down 2 levels and we'll start them there. So we don't start them from like scratch and make them titrate all the way up again. But there's always clinical judgment and different things that come into play, especially, symptoms, because symptoms play a huge role in, kind of managing dosing. So, one of the most important things obviously is like managing expectations with patients and really helping them understand the differences in the medication. So if they're switching from a semaglutide to a dual mechanism of action, there potentially they could experience different things or different symptoms, that type of thing.
All right, so I think this is where I am taking over.
Okay.
For anybody that is new, I do want to also let everyone know the way we function and work. We try to keep people at the lowest effective dose. So we very rarely go up to full dosing. And so just in case you guys are wondering about that. So what do we do if our patients can't get their medication anymore? So, and this is a practice that we even have, is taking a dose less frequently. Sherry mentioned the saturation of the receptors. So sometimes, patients might dose every 10 days and allow the body to work on its own for those extra couple days. But if you're really trying to stretch out the medication, if they have bandwidth on their pen or if they have it compounded, they can lower the dose and see if maybe a lower dose could be still effective for them. That might give them time to switch to a different product. So Sherry shared some of the different ones available right now, but there are so many more coming out. There's now the oral form of semaglutide. I just think there's going to be so many more options. And for some people, we end up switching them to supplementation instead of things that mimic what the GLP-1 medications are doing. And like we said, breaks can be ideal. And maybe flipping that story for your patient to, wow, maybe this is just a chance for us to actually get to what the root issue is. Maybe you will keep the weight off and now you can build the confidence. But this is where we really come in and shine as dietitians too, because we can be there as their partner to help them through. But what I really want to get to, and we're flipping the switch from the medical side of weight loss to the functional nutrition side of weight loss, and looking at that weight loss resistance and what's causing it. Okay, so what happens when you stop the medication? So we have a quiz question or a poll coming up soon, and I'm really curious to hear what you are all finding when people stop their medication, because we see so much out in the media. And at first it was everyone's losing muscle mass. And we've proven in our clinic that that does not have to be the case. But what happens, the med stays in the system around 30 days. Some metabolize faster, slower, but essentially some will still be in the body. But then what? So what we see in media about stopping the medication, and there are definitely studies out there too that have shown this, that patients are regaining weight after they stop it. So I don't know, in my opinion, I think it's causing a lot of fear for our patients and also us as providers with what we should do. However, you can see in this study, and I know it's a little bit busy here, but I'll break it down. So there were 20,000 patients that they followed for 12 months after stopping semaglutide. And you can see in the orange area, those are the people that regained weight. So the dark orange is complete regain. So this is what we are hearing everybody is happening to everybody. Only 18% after a year regained all of their weight back. 26% regained some, but then you'll see 1 out of 5 maintained their weight loss for a year afterwards. So that's pretty significant. And then even more amazing, you can see below in the purple that people went on to lose additional weight. And that was about 40% of people. So I don't think we're being shown what actually is happening after people stop these medications. And I would bet, and I wish we had more data on this, but what we have seen is when, it's not just about appetite and them starting to eat more. It comes down to if they are in a better metabolic state once they stop the medication or not. If they have changed nothing metabolically, let's say they did lose muscle mass and didn't change lifestyle habits, those are the ones that are gaining the weight back. It's not the ones that have made significant improvements in their metabolic health. So yes, this medication can be a crutch or a Band-Aid, but it really can be a breakthrough for our patients. And ultimately, what we need to do is get that body signaling those GLP-1s again. So that comes back to the gut. And, we've found certain foods signal it. Actually, the order of eating can make a big difference in GLP signaling. There are probiotics that have been studied for this and herbs. So, and I think we'll see a lot more of this coming down the pipeline as well. So this is our opportunity as functional nutritionists, dietitians to address that root cause of what is causing the weight loss resistance. Hopefully, if they were on the medication for a period of time, had lost some weight, they've built up the momentum. Now let's really, if they are not able to get on or stay on that medication, how do we get to those underlying issues? So if the medication worked for them, there's likely or was likely some endocrine dysfunction, some gut or liver issues. But other things to look at are inflammation, food sensitivities, autoimmune conditions. Environment and lifestyle is still a huge factor. If you're living in a moldy home or something like that, you still are going to have issues. And then body composition. And that's why we are following and tracking our patients' body composition at least monthly. There are a lot of integrative approaches to support weight management. So, before semaglutide was here, we were still taking care of our patients and helping them lose weight. And we have a lot of years of experience with what we call strategic weight loss, where we are able to help the body get into a state where it can get rid of that visceral fat, that inflammatory fat. So there are other options. Specialty testing is really a great way to show a patient where they have dysfunction. Yes, we can say they have gut issues or they might even know it themselves, but there's real power in seeing an actual test results and them having an aha and being able to do something about it. We do use a lot of supplementation in our practice as well. There are a lot of things that can help with insulin resistance, healing the gut, that sort of thing. And mind body work is a huge piece of this all too. Body image, mindset, how we deal with stressors. Those are all really a big component when we look at weight management as well. And then support groups, get people involved and with others that are going through the same thing and encourage them to work more with you. If they need the support, extra support as they're coming off these medications, that's the perfect time to ask them to work with you. All right, poll number 2. All right, I'm curious on what you will all say. So, what have you personally been experiencing with your patients that are stopping or switching these medications? You can pick more than one answer for this one. Are they mostly maintaining, regaining, losing more? Do they do better when they switch to another medication? So we do have several patients. We typically will start them out on semaglutide. And then if they become resistant or this it doesn't work, we'd switch them to tirzepatide. And then some, I mean, I'm curious if anyone's found these medications haven't worked at all. Okay. So they're mostly regaining what they lost while they were on the medication. Okay, so you guys are seeing that. And you've seen them do better once they switch to another medication. There really are, I think we were surprised too when we started having tirzepatide in our clinic or when we did. We didn't know if people were going to have better results or different results. And the ones that are having a difficult time on semaglutide really seem to do better with tirzepatide. We do have some that are saying that they have maintained their weight loss as well. So that's great to see.
Yeah, interesting.
Okay, I am going to end this poll and move on. All right, what are those biggest challenges during transition or coming off the medications? And we've seen this with all the programs we've had even before these GLPs. There is a psychological piece for people when they are on or off a diet. So something we do all the way through our programs, because people tend to be on semaglutide for a decent period of time. We are talking about what are these lifestyle changes you can make today and tomorrow, and if you don't have the medication. I think it's really important to shift people away from being on or off of a diet. And that's where we start with them when we have them on these medications. What's doable for you? What are some small changes? We don't need to make drastic things all at once. Because if you do, then once the medication stops, they're going to think, oh, I'm not on a diet anymore. We don't want people on these medications if they don't need to be. So we don't use it as that band-aid or that crutch for people. And if people have been struggling for a long time with their weight, and this is the first thing that works for them, they really are going to have fear coming off of the medication, and they're going to think that this is the only thing that will work for me. Now, I would want you to suggest to them, they are in a totally different place. Hopefully, I mean, depending on how long they've been on the medication, how much weight they lost, they're in a different place than where they started. So that does not have to be the case for them. And then giving them the hope by really looking at the root causes. weight is simply a symptom of dysfunction in the body. And if they can understand that, they can feel in better control. One of the big challenges, as you saw with the people that are regaining the weight, that metabolic dysfunction is still there. So, what are some other ways that you can help them in that transition period if they can't get the medication? One, we want to improve their insulin sensitivity. Intermittent fasting is for some people. Berberine has been shown to really help with insulin sensitivity. Exercising strategically. So if you've ever worn a CGM or have patients on them, you can see, right after eating that the rise in the blood sugar. But if you have exercise right after eating, you'll see you don't get as big of a rise in blood sugar. So exercising 5-10 minute quick walk after you eat can be really helpful. And then have them try a CGM. That might be a way for them to get that feedback and see if they still have the insulin resistance, if they have some insulin sensitivity, blood sugar issues, that sort of thing. And then unfortunately, I don't like to have people on restrictive diets if they don't need to be. But if they still have insulin sensitivity, they probably need to stay lower carb. I'm not talking not everybody has to stay, keto, but a lower carb will help with their blood sugar balance. And then hunger. So this can be a really tricky one because, personally, we have seen people that on or off the medication, it is a flip of a switch. Hunger signaling changes significantly. And I don't know that we have the full answer of, what we can do outside of having this medication, but it does help to really think about all the things that drive hunger. So mild sleep deprivation has been shown to increase those hunger cues, stress. And I will, ask you to really push your patience on this one because most people feel like, no, I don't have stress. I handle it really well. And for those that have, an Oura Ring or an Apple Watch and you can track your actual stress levels, people are in shock when they realize that most of the day they spend in a stress state. So bringing that cortisol down can be really helpful as well. This would really be a time to stress the importance of diet with increasing their fiber intake, making sure they have adequate protein. You guys know, this one. And then really looking to gut issues. A lot of times imbalances in the gut, overgrowth of different yeasts or bacteria can also drive cravings and hunger cues as well. So I'm just going to switch over here to something that Sherry and I have created. After I go over this, we'll have time for a discussion. I do see one question in here, Sherry, if you want to just take a look and maybe think about the answer while I'm talking about this. So we launched a course that we did live for the first time back in December. So we had our first group of dietitians go through it. It's 6 weeks, and it's about really feeling like you are an expert in these GLPs. And I hope you can tell from today, we really are bringing a lot of experience to the table, and we want to get our information out there. We want more dietitians to be at the forefront of weight management. And, like Sherry said, these GLPs are not going away. We include a lot of different resources for patients. So we have handouts, we have marketing tools, we even like supplement protocols we have put together and in this course. So you literally can take what we've done and what we do in our practice and implement it for yourself. We offer interactive sessions. So Sherry does half of them, I do half of them. And they're going to be on Wednesdays at 12 o'clock starting May 7th. One really cool thing is we're going to allow you guys to bring your difficult cases to the table and we'll talk them through and help you navigate. I think we all learn that way through our own experiences. And if this is the first time you're here, you probably don't know, but we do bring guest speakers into these discussions. We had someone talk about CGMs. We're going to have somebody in the future talking about fitness at our next one and how that correlates with weight. And so we're really excited about it. And we are in the process of getting CE approval for 10 credits. So again, starts May 7th, and it's going to be just $2.99 instead of $3.99 until the 30th. Sherry, do you have anything to add to that?
No, I don't think so. I think maybe an important thing to note is that, yeah, we're waiting for our final approval and, regardless of whether it's approved within that 6 weeks, we're still going to be offering the CE credits for people afterwards. So I think it's a really good opportunity, a good price to get that many credits. So yeah, that's about it. You covered the rest.
The other thing, so we do have the recordings from when we did it in December and January. So if you order or you sign up today, all of those past recordings are there. All of the content and resources are there already for you. But then you're going to have access and be able to go through it live with us again.
Yeah, because the live course, then we had to modify it a little bit to put more of the learning assessments that are required for CE. So yeah, you can definitely start learning right away, but the live course would be required, or the recording after the live course. So not to overcomplicate it, but there's options to start learning, right now. Do you want me to go to the questions here?
Yeah. Do you want to answer that first one?
What do you think about utilizing Calocurb? Yeah, so I actually did look into it, and I'm trying to remember exactly. I know where there was something about it that I wasn't like super excited about. I think there was a fair amount of side effects, but I guess just to give, a more generalized answer to that, I think there's no harm in trying. I don't know what type of results they're getting, but again, it kind of comes down to addressing, kind of all those other things, and not assuming that just someone taking a supplement and then, eating McDonald's is going to work. But yeah, I mean, I think, there's a lot of supplements out there that I feel like, can be utilized in a more, comprehensive, kind of not comprehensive, more simplistic way. So.
But I will say there are probably a lot more supplements out there that are just there for the marketing
Oh,
purposes and
definitely.
everybody jumping on and anything GLP-1. So I would still, even if you're going to do something like that, kind of like Sherry said, just make sure you're trying to get to the root issue of it. So the key ingredient, I just quickly looked it up, are these hop flower extract. So I would really look to understand, what is that hop flower actually? How is it helping? What is it doing? So yeah, I would also have to dig into that one a bit more to understand it.
Yeah, definitely. Okay, so there was another question about what type of specialty testing we recommend. Well, we do a lot of gut testing. So we use the GI map. We also do food sensitivity testing. We don't do it as much as the GI map. And then another thing that I think is super duper important is to really look deep into the symptoms. When you're meeting with somebody, and most dietitians and functional nutritionists now are looking at other things besides what medications are you on, what's your medical history, that type of thing. Like, we want to know the symptoms, because that's really going to give you a lot of information as it relates to, could it be hormones? I mean, we also look at hormones, but when I'm my whole the way that I think is, I always go to like the foundation. And if the gut is messed up, I would never recommend someone to do like hormone testing, because the gut is like the foundation. It's like the root of a tree. You can't bypass the gut and then just, chase hormones all day. You got to get to the deepest root. So, those are the main ones we do. Yeah, gut, food sensitivity, hormone. I mean, we will do mold testing, because I feel like that is a big piece that so many people are missing, and I wish we did more of it, because a lot of people are dealing with major issues because whether they're currently living in a moldy home, or they're working in a moldy office, or they were living in a moldy home when they were a child, that doesn't leave your body. So I feel like if you're really looking to incorporate testing, mold testing really should be a part of that as well.
To add to that, if someone's dealing a lot with histamine issues, so
Yes.
histamines cause the body to be inflamed and to hold weight. It's really tough if you don't figure out the histamine issue,
Yeah.
for them to lose weight. So, low histamine diet can be really helpful. But again, being so restrictive is not easy or what we want to do long term. There's additional testing you can do to find out if it's the histamine load or if it's the DAO enzyme. So, precision point diagnostics is one that I use for that. I do like the NutriVal, the organic acids. You're being able to see what actually is the cell being able to utilize. You can tell the type of toxic demand and load on your antioxidants and B vitamins. And I've just found moving the needle with patients once they can see their unique profile has been really helpful, because nutrient deficiencies can be a huge problem of it as well. So those would be two other ones I'd suggest.
Yeah, definitely.